as you've heard, my name is Jack Annunziato. I'm Valley's outpatient physiatrist, board certified in physical medicine rehab, and we have offices in Ridgewood, Park Ridge, and in Wayne. Same phone number for all places. Today we're going to talk about back pain, and I want to highlight statistics about the back, talk about the causes of back pain, explain the role of someone like me, a physiatrist, and review treatment options. So, things you should know. 84% of adults will have low back pain at some point in their life. That's 4 in every 5, practically everybody. And there was a systematic literature review that 12% of people will get a flare of pain that keeps them from doing daily activities. So this could be going to work, taking care of kids, driving, grooming, some sort of limitation in quality of life. So it's not that you just have back pain, you deal with it. 12% report it's enough that it prevents them from doing the things that they like. And so what are some common risk factors? And it's actually pretty interesting. So smoking is a big risk factor for pain. Obesity is a big risk factor for pain. Age, the older you are, the more likely you will have back pain. Interesting enough, female gender is interesting. More women tend to get back pain. The next two are kind of combating each other. Strenuous work, and that can make sense. You're like, oh, manual labor, lifting, grabbing, dragging, that can cause back pain. But people who are kind of confined to a desk, a sedentary job, that can cause back pain or lead to back pain. Patients who have low educational attainment, and that makes more sense. They're more likely doing more manual jobs. Strenuous work leads to more back pain. People who are unhappy with their jobs can have back pain and have more back pain. Whether that's a psychological factor that manifests or the joy of a good job, you don't notice the pain. So that's an interesting thing. Back pain cause is really all over the place. And I think the first thing to notice is that 85% of the time, the cause is unknown. It's non-specific. It's commonly it could be a difference of things. Less than 1% of causes of back pain are really serious emergencies. And these are things like spinal cord compression or Cauda Equina, metastatic cancer, infections like abscesses and osteomyelitis. And then there's the 10% of back pain that it's like not serious, but annoying. That's probably the best way to describe it. These are your compression fractures, a radiculopathy, spinal stenosis, ankylosing spondylitis, general osteoarthritis, scoliosis, Bertolotti syndrome. And then there are things that are not necessarily from the back, but can cause back pain. And these are things like piriformis syndrome, or sacroiliac joint pain. So some of these words might be familiar to you. So I always like to talk about what the back looks like when we're talking about it. So you have an example of what a vertebra looks like and what causes space. So we have 7 of these in the neck, the cervical spine, 12 in the thoracic spine, 5 in the lumbars. There are technically 5 in the sacrum, but they all kind of fuse except S1. And then the coccyx is little tiny bones. Those are the bones of the spine. And in the bones of the spine, if you look to the left side of the picture, so your vertebra has both a front and a back part. So that's the body. And then there's the posterior part, which includes the spinous process and the transverse processes. And those kind of meet over here. And in between them, there's this gap, is the spinal cord. And the spinal cord comes down the spine from head to toe. And then you have these nerve roots that come off. Okay. So there's a lot of architecture in the spine that can cause discomfort. But all the neural structures start in the middle and then go out. And I think that's important. And noticing that basically in the body is where the discs sit on, and in the back are like the facet joints. And so when we talk about what's causing the issue, having an understanding that there could be issues from the front of the spine going backwards or issues from the back of the spine going forwards can cause problems. All right. So I will say the bulk of my time gets spent explaining What's a disc bulge? What's a herniated disc? I have a protruded disc. I have disc desiccation. I have all these things. There's a lot of different words to explain what's going on to a disc. But I think if you have an understanding of how a disc is made up of, you'll better understand of like what does these words mean when someone gave me my copy of my MRI. So this is a normal disc and it has a nucleus, center. And when the center has bulges, we call that a herniated disc. So all that is the center has bulged. Now, if the bulge is significant, then we get what's called a protrusion. It's breaking through the outer layer and is going almost to the edge. So it's still contained, but it's breaking through this outer shell. And the bulge can push it, but you're still within the layers. What happens is then we get what's called an extruded disc. The inner material has now escaped, and that's crowding the space. And then sometimes that inner material can get pinched off or sequestered. And sometimes it goes up in the spine or down in the spine, but it's basically pinched off. So there's lots of different words that we use. Overall, all of these are technically herniations, but not every herniation is a protrusion. Not every herniation is an extrusion. So your doctors or your radiologists who might have read the reports will use specific words to categorize these discs. This is a kind of cut and dry picture of like what can happen. And you may have heard these words before. So this is a healthy spine. We have disc, we have bone, we have disc, we have bone, we have disc, we have bone. And then you have that spinal cord again coming through between, and then the nerve roots come off. And so when people tell me I have spinal stenosis, what does that mean? You can have spinal stenosis for a number of different reasons. You can have spinal stenosis because the disc is herniated or bulging or sequestered or protruding backwards towards the nerve root. Some people get arthritic change, which is a bone spur, and that can cause crowding backwards. And some people have arthritis of these joints called the facet joints. They get facet joint hypertrophy or arthropathy, and it crowds this way, and that can irritate the nerve. So spinal stenosis is this catch-all term, but the actual specific reasons could be different at each level. These are some of the more scary things that we think about and why it makes sense to have your back evaluated. So this is including a disc bulge with a little bit of arthritic change, crowding some of the nerve roots here. These are called the Cauda Equina. And that can leave a person losing control of their bowel and bladders, making their legs feel extremely weak and numb. This right here, I don't know if people can see, we have this kind of large mass taking up space, and that could be painful and scary. Similarly, we have an infectious process going on. It's kind of eating away at this bone, and then through time, it collapsed one and then collapsed two. Compression fractures. So there's actually a number of compression fractures here. You have one here. This one is severe because now the bone is crowding the space. And then we have another one down here. And those can be painful. And when they crowd the space, then we can also have pain that shoots down the legs. And then there's another one. This is called Bertolotti syndrome. Basically, when we talk about the bones that go out to the side, the transverse processes, at the very bottom, some people get a fusion of these two bones from the sacrum here. It's a variant. It's not uncommon, but it's something that we know about. So there's a lot of different reasons people can have back discomfort, and it's the role of a physiatrist to help kind of get a better understanding of the why and what to do about them. So let's talk about my specialty, physical medicine rehab, or PM&R, or physiatry. We treat a lot of conditions. So we manage things that affect the brain, spinal cord, nerves, bones, joints, ligaments, muscles, and tendons. Anything that impacts your mobility, your ability to care for yourself, participate in your activities, do things. We interact with a lot of different specialties. Every day I'm talking to primary care doctors, neurologists, orthopedists, spine surgeons, cancer doctors, cancer rehab, OBGYNs for our pregnant ladies with back pain, rheumatologists. I interact with a lot of physical therapists, speech pathologists, occupational therapy, and orthotists who like make braces and stuff like that. We manage a lot of different things besides back pain. So we take care of stroke, spinal cord injury, brain injuries, concussions, MS, burns, cerebral palsy, a lot of different joint pains, neurologic injuries like bowel and bladder, and chronic pain. And, in my clinic, I see a lot of things like migraines and TMJ, obviously your classic neck and back pain, which is what we're talking about today, but also things like golfers and tennis elbows, rotator cuff problems, knee pain, plantar fasciitis, cancer pain, all sorts of stuff. Physiatrists work in all different settings. So I work in an outpatient office, but you may see a physiatrist in an acute care hospital, a rehab hospital, or even a skilled nursing facility. We're in spine centers and pain management practices and orthopedic clinics. And we have a lot of tools in our toolbox, where it's all about promoting quality of life. So that could be exercises, going over medications, physical modalities, things like heat, cold, OMT, which I'll talk about in a little bit. We help work on mobility. We help work with adaptive equipment, things like braces, wheelchairs, things that help with like foot drop and stuff like that. And we often do injections. Some of us do them in the spine, some of us do them in the joints, some of us use x-rays to guide them, some of us use ultrasound to guide them. But we have a lot of tools in the toolbox. So what should you expect when you come to see someone like me? You should expect a thorough history. I'm going to ask you a bunch of questions related to your pain. I want to get to understand why you're coming to see me, the reasons, and all the relevant history. We're going to do a comprehensive exam. I'm going to check your strength, your sensation, reflexes, if it's appropriate, your balance. I may do special tests for each specific joint that's bothering you to get a better understanding. I order different tests. So those can be things like X-ray, CT, MRI. Sometimes it involves blood work, especially if we think there's like a rheumatologic issue going on or some other metabolic problem. I may order what's called a nerve conduction study or an electromyography exam. And that might be to test the nerves and see how they're performing when called upon. And then we go over a bunch of different options. And like I said, I have a lot of tools in the toolbox. So we may talk about medications, different procedures, different braces or adaptive equipment, certain therapies that they should participate in, or home exercises if they would prefer that. Or maybe I'm not the right doctor for you, or we've done a lot of those things and it's like, all right, now's the time to talk to a surgeon, or now's the time to talk to a rheumatologist or a neurologist. So, not afraid to share the care, especially when I know my limitations and what I can offer you. Oh, going fast. Okay. So I get a lot of questions. Oh, what am I going to give are you going to give me opioids? And it's like, truthfully, they're the last thing I think about. So I do a lot of NSAIDs or anti-inflammatories, and those are things like ibuprofen, Proxen, Celebrex, Loxicam. Sometimes we work with muscle relaxants like cyclobenzaprine, Valium, or baclofen. I do a lot of nerve pain management because a lot of times people get peripheral neuropathy or tingling in their legs, and that would maybe be beneficial from gabapentin or pregabalin, which is Lyrica. Sometimes antidepressant medications are the right choice for a variety of reasons. And so we talk about medications like Cymbalta or Effexor. Sometimes we talk about medical marijuana, and that can be useful, especially if there are medical comorbidities that prevent you from maybe having anti-inflammatories. Maybe you're on blood thinners. It's not right for you. Or you have kidney problems, and certain medications will throw off the kidneys. And then lastly, there is a role for opioids. I don't love giving them out, but for the right person, I can help you get coordinated with a doctor who does that. But it's a tool in our toolbox. And then procedures that we do. So a lot of cortisone shots, shoulders, elbows, hands. It's basically any joint, we can put cortisone in it. The insurance will cover gel shots for the knees, and we do that. Some of us do what's called platelet-rich plasma injections, which are not necessarily covered by insurance, but could help regenerate some damaged tissues. We do Botox injections for chronic migraine, and some of us do spine procedures. So there's sacroiliac joints, and you may be familiar with some of these terms like an epidural injection or a medial branch block or radiofrequency ablation. And one of the last things that I specifically do is something called osteopathic manipulative treatment. OMT, or osteopathic manipulative treatment, is a set of therapeutic techniques that someone like myself does to move your muscles and joints using some different stretching, some pressures, and some variable resistance to kind of help promote better function. And a lot of times I have patients who ask me to try to do this because it can replace a medication or try to delay surgery. It's very similar to chiropractic care meets massage therapy, and I'll show you some examples. So this is an example of sub-occipital release. It's a soft tissue technique for the neck, where I'm basically applying a gentle pressure under the tight trapezius muscle to encourage a little stretch, to increase motion, encourage fluid circulation along that soft tissue to help mobilize the neck. This is what's called gluteus muscle energy. It's basically a hip low back stretch. I'm pushing the patient's hip to their opposite side. They're pushing against me. And then when they rest, I can stretch them a little further. It's a resisted stretch. If you've ever been to an athletic game, basketball, football, in the pregame warm-ups, you may see athletic trainers incorporating these types of stretches to athletes before in warm-ups to help get them loose before they go out and compete. But not everything is a direct technique. Not everything is a push-pull. There are different techniques called counterstrain, where I just guide the muscle into a position of maximal ease and wait for a relaxation. Usually this takes a bit of time, 60 to 90 seconds, but some of these holds allow the muscles to relax. And you tell them, hey, listen, this is a soft, okay motion. You can calm down. And then once I break that muscle's resistance, then we mobilize the joint into a position of comfort, and that can be helpful. So all in all, that's my role as a physiatrist, addressing back pain, trying to tease out the different causes of back pain, and coming up with a plan for you that kind of fits your needs and your goals, and is appropriate and healthy for you, whether that's medications or procedures, or all sorts of stuff. So at this point, that's the end of my slides, but I'm happy to field any questions that you guys might have.
Oh, thank you so much, Dr. Annunziato. So thorough. I'm waiting for some questions. I'm sure people are thinking about, a lot of what you're saying. I had a question about like some holistic treatments that are you have any familiarity with them, and how do you work with those types of treatments, Doctor?
Sure. I get asked all the time, I don't want to necessarily take a medication. What are your thoughts on like acupuncture? Acupuncture is great. I refer often to people for acupuncture. Some people like different like aquatic therapy, which is a offshoot of physical therapy, and Valley has an aquatic therapy program up in Mahwah that I'll send patients to. There's different yoga programs and Pilates programs that I've kind of helped people kind of go through to talk about managing their pain, and I'm open to listening to everything and meeting a person where they're come from. So I say bring it to the table. Let's talk about it.
So it's kind of person by person. If a lot of people have questioned about yoga, and just basically to talk to you about that and person individually. It's usually an individual thing, is what you're saying, right?
Definitely an individual thing. So some people I would say, are too flexible. Some people are not flexible. Some people can do a lot of the yoga positions and it's appropriate for them. And sometimes there are certain yoga positions they should avoid. So, bring it up to your doctor, bring it up to me. We'll have a conversation. And we'll talk about what, sometimes it's like, all right, you can do a flow-based yoga, but don't do any cobra pose because the extension might bother you. So we talk about those things. Yeah.
Okay, great. Um, so if someone has a degenerative disc disease, like what do you typically do for something like that? Can a physiatrist help that situation?
Yeah, so absolutely. So, part of the issue is getting them out of pain.
Hmm.
So there's meds and procedures and stuff like that to get them out of pain. And then there's a prevention component, and that's guiding through home exercise programs or physical therapy to kind of keep the core strong. Uh, and that's usually our approach. It depends on how severe and what limitations are, because a degenerative disc at L2 impacts the body differently than the L5S1 disc. Some people with degenerative discs have like issues with walking. Others, it's all kind of upper back. We have to figure out what that means for them. So partially, it's teasing out the why and helping to understand exactly um, uh, what's been tried before. A degenerative disc goes back to this. It's how degenerative is it? Is it all the way out? Is it squished? What are we talking about? So it's one of those things that we have to kind of sit down and discuss. But yes, we have a bunch of options. They are all amongst here. Good question.
Okay. Someone was just asking a little bit about like your services. So physiatrist, just to clarify, physiatrist versus a physical therapist, like physical therapist. Just kind of talk to that again a little bit.
Sure, sure. So I'm a physician.
Hmm.
So I make medical decisions and assessments, and I do procedures. One of the things that we can refer for, if I think it's useful, is sending you to physical therapy. They're the ones that maybe are going to see you twice a week, do the specific exercises that I recommend, um, guide you through the exercises, but they're going to see you a lot more frequently. I'm kind of the physician backing. I made the medical decisions, kind of come up with the plan, and they kind of execute the plan. I hope that makes sense.
Yes, that does. So as far as designing like an exercise program, would that be more what a physical therapist would do, or would you do something like that? Or
Sure. So I do it. Um, and usually, if it's a home exercise program, it's just me and you. If for whatever reason, the guidance of having a physical therapist is something that you want or need, or it's motivating, like I know if I made the appointment, the commitment, I will go and do it for anything. Uh, the orders that I give you when I write the referral order of physical therapy includes things that I want them to do for you, and they'll guide you through that. It may be a warm up with a little bit of heat before, and then a stretch, so I kind of write detailed physical therapy orders that they would then execute.
and they execute great. So somebody's asking about, excuse me, retrolithosis
Yeah,
with disc, oh boy, osteophyte complex and facet osteoarthritis. Is that something that you could talk
absolutely.
about a little
So
bit?
I'm
And
gonna go back. So do I have a picture? I'll just go with this one. So retrolisthesis is if the bone here shifted backwards, all of it. And so if the bone shifted backwards, I'm just looking at the chat box. The bone shifted backwards. Part of our program is to how do we address that? And it depends on how much is the shift, um, and how much crowding is. But yes, that is something that we address. Sure.
terrific. Someone was just something asking about just a procedure, like having an ablation,
Mhm.
a few months ago, and is constant sharp pain, like a sciatic or in the rear, a common issues, and is that something that you've helped with?
Sure. So I have a number of patients who have had those procedures. I don't do that procedure, but I often make sure that it's the right procedure for the right patient. So, when you come to me, we're going to have to do an assessment and get an understanding of is the pain going down the leg or is it staying in the back? Because usually facet ablations, usually it's pain staying in the back. So if it's going down the leg, it might have just been the wrong target, and we have to adjust the target. But that is something that we address often. Yes.
Great. And do you accept Medicare for our
We
senior
do.
use and all? Okay, that's important too for arthritis and all, treating arthritis.
Mhm.
All right, that's wonderful. Oh, okay, hold on.
Mm.
And one more we'll do. Can you talk about, oh boy, piriformis syndrome,
Sure.
PIRI, and manual manipulation?
Yeah. So piriformis is a muscle in your buttock. It can be a tight muscle. It can be very sore. It can make a lot of pain to sit down. Um, so part of using manual therapy is to shift. So let me see if I can change my slide. So a technique that I would do is similar to this one, because I'm kind of stretching it. It's just a different area. So this was focusing a little higher up on the glute. Piriformis is a little lower. It's more of how I just approach the contact. But that's absolutely something that we see. And there's also usually piriformis syndrome is combined with some other like ankle foot stuff. So I always try to make sure that your ankles and your feet, you're wearing the right shoes, stuff like that. They usually go hand in hand.
Okay, great. All right. Well, this was wonderful. It's great to become familiar with this wonderful area of medicine. You know, it really is, it helps with function and pain management. So thank you so much, Dr. Nunziato.